Thank you very much, Karen. We will hold questions until after the panel discussion. Terry, if you will come up, and your panel members, if you will come up and have a seat up front, we'll begin the panel discussion. While we're doing that and waiting for all to come, let me just introduce the program staff that makes these meetings possible and successful. They're usually sitting in the back or the side, but I think they should just stand for everybody's recognition. Rosemary Martinez is over there. Rosemary is the project board member. Lila, just say hello. Melissa and Alexis. Is Alexis in the room? Yes, there she is. Thank you very much once again for putting all this together. Terry?
Am I on?
You're on.
I'm on, okay. So I'm Terry Davis. It's great to be here. I have a very cool panel, and this is a panel that will discuss health insurance understanding and enrollment through a variety of lenses. These three women are from New York, California, and Louisiana, and they had very different roles in helping uninsured get health insurance through federal or their state insurance marketplace. They have stories that are very informative for all of us. We had a conference call that was very informative for me. And here's some bottom lines before I'm going to introduce them and ask each of them the same questions. But here's the bottom line I got from the conference call. Health is personal. Health insurance is a learned process for all of us. A cookie-cutter approach to national health insurance enrollment and helping people once they're enrolled won't work. States vary widely, we found out on our call. Insurance plans vary widely. People vary. Situations change. People's situations, insurance company situations. Life changes, it's dynamic, so there you go. So Elisabeth Benjamin is a lawyer, a public policy expert, and a biker, I found out this morning.
City bike.
City bike, okay, from New York. And she was awarded a $5 million Navigator network contract that enrolled 100,000 people in 61 counties. And that you also work with 150 community organizations across the state?
Not all through our Navigator program. In our Navigator program, we have 37.
Okay. So then Jan Flynn of Black Women for Wellness has a 30-year, I had dinner with Jan last night, 30-year history of, in my opinion, boots-on-the-ground public health work. And she's doing what I thought was just really novel. She said that's just what she does, is that she realized that in a surrounding area there were 60 beauty businesses, salons, barbershops, nail shops. I mean, those California people are into beauty. But at any rate, she realized that this was a great way to meet people when they're relaxed and inform them about health and health insurance, and she'll tell you that. Jannette Mentesane is an old friend of mine. She is an incredible director of a free clinic, the Martin Luther King Clinic, that is 30 years old in Shreveport. And she got a contract with our state to enroll people in North Louisiana. Our state had a lot of negative publicity about ACA, and the governor was very against it. At that time, we have a new governor. And she will tell you her story. So I want to start out, and what I'm going to ask each of you, beginning with Elisabeth, what was your role in your state in New York in enrolling people in health insurance, and what was unique about your state? Also, Elisabeth has a handout. She had slides, and I said no slides. So she has a handout. But, okay, Elisabeth, what was your role in your state, and what was unique about New York?
Well, I had the incredible opportunity to coordinate. Whoop.
Is she on? Is that better?
Am I on now? Is that better? Can you guys tell a difference? Okay. The New York State of Health, I'd like to first talk about our marketplace. I think in many ways, New York has the most extraordinary marketplace in the nation, and most extraordinary, perhaps not in terms of the visual and Silicon Alley Valley, depending on which coast you're on, optics, but most extraordinary for its functionality. What New York does that no other did, except for Kentucky, and now Kentucky's dismantled theirs, is it does simultaneous enrollment in every possible form of coverage. So you could get into a commercial qualified health plan if you were wealthy and just pay full freight. You could get a subsidy, a tax credit. You could get cost sharing. You could get the new basic health plan if you were eligible for that for people who are lower income but not Medicaid eligible. You could get Medicaid, or you could get Child Health Plus, which is our children's health insurance program. So, or if you were an undocumented immigrant, you could pre-qualify for emergency Medicaid or pre-certify for emergency Medicaid should you have a catastrophic event happen or something that would qualify you for emergency treatment. So it's sort of a full force functionality, and that was incredible that New York did that. The second thing that I think New York State really did right, which is where we sort of become involved, is it really invested in a robust Navigator program. And we have over 50 Navigator programs in the state. Mine is the largest one. As you said, it's a $5 million a year contract. There's $30 million a year invested in New York for their Navigator program. Poor Jan from Louisiana had a very different experience. More to come there. But ours was quite good. And what was unique about our program is that we tried to partner with alternative kinds of community-based organizations, people that were not traditional. We did have some traditional Medicaid enrollers, but we really tried to get non-traditional enrollers. And so in my slide deck, I talk about a rural community organization that would enroll people at their kitchen table and family farms, in rural areas in New York. We'll talk about the challenges there. We're very different than our urban enrollers. We also use very small immigrant-serving community-based groups, and I highlight one of our South Asian immigrant-serving groups. And their strategies really went more to what Jan will be talking about, of going to where the people are. So that's gurdwaras, that's mosques, that's the local bodegas, like local community-based areas. And I think and then we also had chambers of commerce who would reach out to small business serving groups, Young Invincibles that would really target community colleges. So we really tried to figure out, taking a pie chart like what Karen displays and making it real. Who are the right partners? Where are these uninsured people who are not likely to just be able to go online like that and talk to a call center? Where are they going to go? Who are they going to use? And that's what we try to offer through our network of community-based agencies, whether they were small business serving or individual serving.
So Jan, what was your role, and what do you think was unique about California? Turn on your little...
Hear me now? Since we are broadcasting via the internet, I feel obligated to give our website, which is bwwla.org. And we use that as part of our outreach also, just in terms of to make sure that we had a very robust social media and internet strategies going on. So my role, I am the executive director of a community-based organization, Black Women for Wellness, and we are 19 years old. And in our 19 years, we have been doing a multi-generational approach to outreach. So yes, we found ourselves in the whole beauty industry. So and perhaps that is part of California in that we go to beauty salons, we go to barbershops, we look at the beauty colleges because of the target audience that we had, which were African American and Black women. So in addition to that, because it was multi-generational, that's where we also found ourselves looking at young women, looking at girls, looking at seasoned women, looking at mature women, and just to figure out what our conversations were and what type of information that was needed. So in addition to our beauty shop outreach, which we called Perfectly Natural, we also did Super Soul Sundays. So Super Soul Sundays, we trained people who were in faith-based institutions, not only Christian, but I know we had a large contingency of people who practiced Buddhism. We had the Nation of Islam involved, but basically we trained advocates from those organizations and faith-based institutions to do outreach, and then we provided everyone with all types of health education materials to do that. We had memes, we had little videos, and our role really was to do information. One of the advantages about California is that we jumped out front and said, we're going to do this in California in terms of the Affordable Care Act, and the private foundation industry got behind that also. So they were very much looking for coalitions and networks and community-based organizations working together to share information with our various communities. We also had a robust information system with our ethnic newspapers and news outlets. So not only Black newspapers and radio stations, but Southeast Asian, with Latino, El Mundo had a huge thing. But that was all about getting the word out. And at our organization, we made a big distinction between doing outreach and education and enrollment. I felt, and this was my personal thing, that enrollment was going to be a totally different ball of wax than that outreach and education, and that turned out to be so true. So folks who did the enrollment had to spend much more time, had to have much more information about the various health plans, the various options folks had, and also when I say health plans, I mean Medicaid, Medi-Cal, whatever people were going to use, CHIP, etc. And this was not a one-time visit. I know you said that it took 90 minutes on average to enroll a person, but that was the first time they saw someone, because invariably they were going to come back and ask for explanation and more detail and why this bill was not what they expected. And they just didn't put that in the equation of how community-based organizations and navigators would get paid to do that. So that's why we made a decision just to do the information and education piece.
Great. That's a great segue into Jannette. So what was your role and what was unique about Louisiana?
Well, we didn't have a very positive role in the organization.
Oh, your mic.
We started out, to begin with, I'm the executive director of the Martin Luther King Health Center and Pharmacy. We're a free clinic and free pharmacy in Northwest Louisiana. The majority of our patients are chronically ill patients, and we mostly from Caddo and Bossier parishes, but we do see people from all through Northwest Louisiana. I initially applied to be a Navigator site to help our patients, to see what we could do for our patients. Come to find out afterwards that there was 4 entities that were funded in Louisiana, 3 from south of Baton Rouge, and we were the only one in North Louisiana.
And $86,000?
$82,000 to cover, right, and $82,000. And there was one entity that was South Louisiana that was supposed to be statewide, and they had one navigator that was placed in a town Natchitoches, Louisiana, which is still 75 miles south of Shreveport. So here we were with $80,000, and to be a navigator entity, we were supposed to do outreach and enrollment. And my initial plan was basically to do this for our patient base. And then we found out after the fact that we were covering all of North Louisiana. The first thing we had to do is defend ourselves in the state, not only with the Louisiana Board of Insurance, but also we were selected initially before even the enrollment process came out. That Congress, because of all of the oversight issues, and it was such a highly politically charged issue, that we were one of 3 Navigator contracts that were selected for Congress to question us. So before we even got off the starting block, we had to set up a conference call with attorneys from Congress on both sides of the aisle, had to have our board attorney, and they grilled us for 2 hours on the phone about what we were going to do, what we were going to do with the money, how we would protect patient information, and it was like, we're a medical clinic. We already know how to do that. What we were going to do with the information, if somebody signed in, how do potential enrollees come in and sign up in the clinic, pad of paper, questions like that. And what do we do with those names? I mean, it was ridiculous. Then we had to go to the Louisiana Board of Insurance. That was very negative. It would create a hostile environment between the insurance industry and navigators, which I think was a lost opportunity because they're the experts, and we should have been allowed to utilize the experts in the insurance industry to help us educate consumers who did not know that much about insurance. The oversight was from the monitors was, and I think it was all because it was such a highly politically charged issue that they didn't want to have anything happen. So weekly conference calls, all kinds of paperwork and reporting and everything. It was just very labor intensive, and it was not flexible at all. We were working with a lot of our patients. I'm used to calling them patients, so I use that term. It's because I work in a clinic. A lot of our clients, they've never had an email address. They were not used to keeping track of passwords. A lot of them had no bank account. They'd never had a bank account. Some of them did not have a phone, or if they had a phone, the number changed on sometimes for a weekly basis. We see that in our patient base, trying to call people back. And so when I was trying to work with our program monitor to explain that, that's one instance that I would want to explain to y'all, is that I would tell them that our folks are trying to help somebody establish an email address, and then we were not allowed to, according to the rules for to be a Navigator site, you were not allowed to keep any of that information. You were supposed to help them, set up an email address, password, and then give everything to them. Well, a lot of folks are not used to keeping up with that. So then when they would come back to us, it was starting over the process again. And so it was very labor intensive, and there was no flexibility. When I would ask our program monitor, have an idea of what we could do, have a file on a particular person and keep that information for them, because we are used to keeping protected information because we're a health center. And they absolutely came back and said, no, we can't do that. So there was no flexibility to work differently with different programs in different parts of the country, I think. I think that was probably a very negative thing. I think that they thought that everything was going to be, this is what the rules are, and it's going to work everywhere. And that was not the case. Shreveport, Louisiana is on the opposite side of the state. I always kid people, Terry and I know that, it was like we're in a different country from New Orleans and Baton Rouge. Our population base is completely different. We have a large rural population, and it was extremely hard. And with $80,000, it was not very, it was extremely hard.
So I'm hearing you all face challenges. I'm hearing y'all all were bidding to what people trusted and where they were, where they felt comfortable. So I want each of you to talk about what challenges did you face and when the feds or the state orchestrated something, designed it, and then the rubber meets the road with what you all are doing. So Elisabeth, what challenges did your huge network face?
So, everything's local, and that's true in New York too. So New York is a big state. We have 62 counties. Yes, we're in every county but one. It's Chemung. And the rural areas are really rural, a lot like what Jan's talking about, and the urban areas are really urban, a lot like what Janet's talking about. So we have both. And the challenges are different. In rural areas, a lot of places, there's no internet connection. This is an internet-based platform, and that makes it really hard. So, we would like to be able to go to everyone's farm, but sometimes the farmers had to come to like a local library that had an uplink or whatever and meet with our enroller there. So like the Burrs, with this family farm we profiled here, they had, limited, and it's a fake name, fake picture, just, I don't want you to think I'm disclosing any privacy, but this is like a pseudonym for, a family we helped. They had, a $5,000 a month deductible plan that they were paying $850 for. By the time they got to us, which was not in year 1 actually, it was in year 2, when we enrolled them, they were eligible for free Medicaid. Right? I mean, that's the change you can make in people's lives. But the challenges faced in rural communities, no long distances to drive for navigators. You have to pay navigators to be able to transport, to get to places. You have no internet connection. Those were, I would say those were the 2 biggest single challenges just that were rural, unique to rural areas for us. And then just actually one more, just this real belief that there wasn't going to be anything affordable. Right, that there was just not going to be an affordable option for them. In an urban area, same belief. There's nothing that they're going to be eligible for. That's all going to be unaffordable. So then you have to overcome that. But in urban areas, you'll have much more diverse populations. People that don't necessarily have a good relationship with government over time. That's, in many of our outer boroughs, there's been a long sort of not great experience with government and government entities for immigrant populations. You have language issues. If you call a call center and do this sort of long, laborious translation for insurance, which is the most complicated thing, I mean, it's just not the way you're going to enroll someone whose language first language may not be English. And so in that way, you have real challenges in urban areas about finding people who are eligible for these programs and then actually communicating with them. And then on top of that, we have navigators. There's other issues. So for example, we have a lot of people who are from the Muslim community, and some Muslim women, not only don't want to have their image disclosed, then we have to make sure we shred any images that might be uplinked for document, verification, but also you have to have a female navigator, right? So you have to really think through for each population you're working with, what are going to be the challenges. And I'm not the expert in that. And that's why we partner with really, really on-the-ground community-based groups. That said, I do enrollments. I've done several hundred myself. And I can go on and on, which I will not write at this moment, talking about just the regular insurance challenges that, like Karen was touching on. And I think we should come back to that. And then the one thing I just wanted to say is what isn't in this program is any kind of sort of flexibility for the boomerang problem. And the boomerang problem is that clients come back, and they come back and they have problems, and our navigators are not trained to really deal with post-enrollment issues, which are quite complicated. And there are a lot of different laws. There are a lot of different agencies, even in our state. There are 4 different regulatory agencies, just depending on what kind of coverage you have. And if you're going to have people doing post-enrollment work, you really have to have them highly trained and backed up by people that understand that legal and regulatory.
Know that they're going to come back. So Jan, what about you? You were saying y'all made a distinction between outreach and awareness and enrollment. What challenges did you face in any of what you were doing?
Well, just to build on you call it the boomerang impact, we knew people were going to come back. Because utilizing your health insurance is a behavior that is learned. If you grow up in a household where you have health insurance, they teach you how to use it, and it becomes ingrained in your culture. And if you're just getting health insurance, then one has to learn how to use it. And so we knew people were coming back. So that was one of the things that we foresaw, that people would be coming back, and it needed a system and a structure to make that happen. To talk about the internet challenges, California is huge. We have both rural and urban, and that internet challenge is in the urban area also, especially what we call, or they used to call the last mile, in terms of when you get deep inside the urban centers, internet just does not work or is extremely slow, and it wouldn't be on long enough to enroll people and take them through the process. So the internet, and then that also made the assumption that they had internet, and they could afford the internet that they had. So that was, we knew that was going to be an issue also, and it turned out to be. Other issues became trust, in terms of here's another government program with a population that has not been trustworthy with our government. So, you know, will people trust that this program is going to work for them? Especially in that a lot of times the price that was quoted to people would not be the price that they got back when the enrollment finally happened. So it's like, okay, now we have two different prices. I knew I shouldn't have trusted this process in the first place. So the trust was not there. When we talk, the area where our office is in Los Angeles is a catchment area of 1 million people, no hospital. So there was still that issue of, did we have healthcare providers? And that became part of the issue of choosing a plan also. It's like in the geographic range, because it's very spread out in California, where there are healthcare providers who were culturally and linguistically competent in the area that you could get to, especially if you needed to get to in an emergency or if something was happening. So finding a provider in your catchment area or in a close geographic area was a problem also. And then transportation to get to that person or to get to those centers where you needed health care. Our transportation system in Southern California has work. It just needs work. That's all I can say about it. We're a very car-centric place. And if you don't have a car, then it becomes quite a challenge to access health care if you're using public transportation. And especially if you have to travel quite a distance to use the public transportation. So there are very layers of issues and challenges that came with enrollment, trust, cost, cultural competency, and geographic location are just a few. And then really having that person that you could talk it out with.
So a person, I'm hearing trust and a personal connection, expect a boomerang, and you've got to think about culture and language and access. So what about you, Jannette? What were challenges that you faced?
Well, besides the big one of being severely underfunded and trying to cover a large area, which I think after the fact, I would think that the federal government would have tried to readjust that because they would have seen that it was not, as far as, was not feasible to be able to cover that. The other thing is that coming from our patient base, who are chronically ill patients, a lot of them taking hundreds or thousands of dollars worth of medications monthly, the deductibles, the plans, the deductibles were so high and co-pays were high that it was not, it was difficult for them to find a plan that would really work for them, to where they could maintain their health until they met deductibles. The other thing that we noticed is that when premiums, and like you were mentioning, premiums, once they've got the paperwork, they may have enrolled in a policy, they've got the initial paperwork, and then they didn't pay the first premium because the premium was higher, or they may pay premium for a few months and then life gets in the way. I mean, if you're going to, you know, we have a lot of seasonal workers based on construction work and that type of thing. If there's a rainy season and somebody's not being able to work very much, then they're going to pay their rent and utilities and not that health insurance premium. So those people would flow back off the insurance rolls. So we find that it's very fluid. People are on and off those rolls, and they're real happy. They might have a policy, and then 2 or 3 months later they're back at our clinic again because they're uninsured again. So that's some of the very.
Tell why you quit, stopped it.
Well, yes, we did the first year, and then we did an extension through March of 2015, and it's basically because of labor intensive, the underfunding, and it was very labor intensive for us and for me because we have the way our clinic is set up, I've got 10 paid staff, 5 part-time, 5 full-time, but they primarily work in our clinic to keep our clinic going, and that's our primary mission, is to provide health care and health education, prevention education, and we have a pharmacy. All of our healthcare providers and our pharmacists and nurses, they're all volunteers. So, you know, we needed to fulfill our main mission, and it was so labor intensive of trying to do the reporting, and then we realized that at that time, Louisiana did not expand the Medicaid system. So there were so many people in the gap, they did not qualify for subsidies, they could not, or the deductible was so high that it was, our board basically decided that for us not to do that, not to continue.
Elisabeth, you had a comment?
Yeah, I mean, I think it might be helpful, since this is a health literacy roundtable, to maybe talk through the steps of enrollment, because I'm not sure how many people in this room have actually gone through a full enrollment. And so could I just quickly go through that?
Quickly, because I want to ask y'all a couple other questions.
Oh, okay, well then, why not?
Well, one was, and maybe you can segue into this, they have sort of talked about their lessons learned, but I want to know what resources, now with all your lessons learned, what resources do we need now with the situation the way it is, with people varied, insurance plans varied, the boomerang, people not paying because life gets in the way and then they lose it. So what resources, Elisabeth, do you think are needed now?
Well, I think the project is now much harder. You know, we're in the last, you know, miles, you know, 100 miles, whatever it is. But the people who are left who are not enrolled are the folks that really need the in-person assistance. These are not the people that can go onto a website and enroll by themselves. And unfortunately, it's ground game. You know, it's a you know, street by street, village by village, hamlet by hamlet, and that is really resource intensive. And so my biggest worry is that they're going to start de-resourcing the Navigator programs just when it gets even harder and slower and longer. I think that would be one bucket, is that I worry, you know, oh, we're done, the Affordable Care Act, it's all over. You know, we've enrolled, you know, whatever it's going to be, 60% of those eligible in a good state. But there's that other 40%, and that's a lot of people, and we shouldn't give up on them. And they just, it's, you know, but it's a ground game. The second thing I would say is that it's a shame that the administration, the federal administration, and folks in Washington have decided to not fund the consumer assistance programs. These are the post-enrollment programs for everybody, not just people under the Affordable Care Act, but people who have job-based insurance. If you have job-based insurance and you get sick, you might need to file an appeal because you might be denied a stem cell transplant. Or, you know, you might be denied that special cancer treatment, or the drug you need because you have one genetic form of cystic fibrosis that isn't on the plan's formulary is going to be denied. And people don't know how to do that by themselves. They don't know the rules of engagement, which it can feel like sometimes if you're an enrollee with a health insurance company. And we just have decided to give up on that consumer protection aspect of the law, and I think that's a travesty.
So the bottom line with this personal help is that resources are needed for the group that's left, or the group that's lost it, boomerang for whatever reason, need personal help that's accessible. Jan, what about you? What resources?
I actually very much agree that we do need those patient navigators for all insured, whether it's private insurance or public insurance or some hybrid in between, because navigating the healthcare system, especially if you're ill, is a challenge. So that resource is needed. I also think the role that community clinics, fairly qualified community clinics, free clinics, et cetera, is critical right now. They catch all those folks who have given up trying to navigate that public health system or even a private system sometimes. And they also are those people who were frontline in the community before the Affordable Care Act. And so they're that front line that people revert back to. So they are still very much needed in terms of the critical care that they provide that is essential to folks who are newly insured or folks who even want something close to where they live. I also think that the coalitions that were formed to make this happen are still needed. We didn't create this problem of uninsured in 5 years or 10 years, and it certainly won't go away with 5 years or 10 years of resource. It needs to be bolstered until it is ingrained in our culture.
Right. It was lessons learned for all of us. Nobody was saying deductible copay 5 years ago or 6 years ago, or few were saying that. So Jannette, what resources do you think are needed? What would have helped you? What resources?
I think what would have helped us after the Navigator grants were funded would be for the federal government to recognize the problem in Louisiana, the way the the organizations were funded. That 3 were from South Louisiana, 1 from one small organization at $80,000 funded north of Baton Rouge, which is a lot of territory, and that it was not going to be a feasible plan to try to do both outreach and enrollment with part-time navigators. I think that could have been handled better. I think that the plans need to be, the monitoring and the whole program needs to be flexible according to the population in the state and the geographic area where these programs, where the navigators are coming from, because not all, one size doesn't fit all over the country. I think the plans themselves, the insurance plans, we need to do something about the deductibles and maybe design some other type of plans for people that that are more affordable. Just a variety of different types of plans. There are some, I know that because every plan had to cover everything, and so that drove the cost up to me of the premiums for everybody. Whereas if it's somebody like me, my age, I do not need maternity care for an insurance policy. So, so I think that it was so rigid and not flexible, I think is a big problem.
I disagree with that. Actually, I mean, are we allowed to have a disagreement? I think actually one of the geniuses of the Affordable Care Act, and maybe Karen's really an expert, was that we actually had a basic, you must have these bottom line floors of what insurance is. Now, I think there are ways, and interesting ways, to tweak it to get to what Jannette wants, which New York State is now doing, which is, for example, a silver plan has quite a substantial deductible. And if you don't have a cost-sharing reduction, you're going to be looking at a $1,700 deductible before you can even start using your care. And so what we have been trying to do in our state, and the federal marketplace is also doing this with our standard product, is saying, look, let's have some services that are more services besides just preventive care to be pre-deductible. Let's give somebody 3 sick visits. We'll expand the maximum. We'll figure out how to fix it, tweak it on the actuarial side. But I think we have to have those 10 essential benefits. I think the whole way insurance works is a solidarity principle. And if you have to have everybody in the system, and if you start saying, oh, we're not going to cover maternity care, or we're not going to cover cancer treatment, it won't work anymore. And Karen's really an expert on this. She's seen over and over policies that have fallen apart because they precluded certain services or not. So
we can talk more about that when y'all ask questions.
Sorry.
No, that's fine.
Imagine how robust our conversation was on the telephone.
Yeah, right. Also, people are different, their situations are different, and states are different. So, really quick, because we have 5 minutes, is that it? Any bullet points about what's needed to help people retain and use health insurance? Talked about the boomerang of not knowing enough initially, but then y'all talked about losing it because of life circumstances. Any bottom lines on retaining, Jannette?
To me, I think flexibility is the key, and not only in implementation, but also in actual plans themselves. I think, of course, the next step is, reforming the whole healthcare delivery system, but that's another issue. But anyway,
I agree with that.
But I think that from something that Jan said earlier that we found out also is that it helped to do. You needed really to do education sessions before there even was an enrollment process, to work with people because of so many people who they don't understand the basic insurance. And then the other thing is to partner with the insurance industry, that the insurance industry needs to be a big help in this, their expertise.
Okay. So flexibility, partnering with the insurance people, at least in Louisiana, because they had expertise that the navigators didn't.
Right.
And there's a difference in outreach and training and enrollment.
I'd like to do a plug for New York State. One of the things that they did very wisely on renewal is have the least amount of documentation required possible. I mean, people's lives at the end of the day don't really change. For, at least the populations we're dealing with, we don't see people having their circumstances change a lot. And having people reprove their life every year, like the old Medicaid programs used to do, that is, I thought, a genius in the Affordable Care Act, that they gave the states the flexibility not to require people to reprove. And we've just seen our churn rates in New York really plummet as a result of that. And I think that really helps lead to long-term retention. And then the other thing I would say that really helps retain people is one of the things that our state did that I thought was quite remarkable is, bless her soul, but the woman that runs all these contracts for all these Navigator programs, including mine, would get on the phone with us once a week for an hour, a 50-person conference call. Can you imagine? And we would talk about every little problem, every little system glitch, and she would, get it back to the people who could make fixes and changes and tweaks. And I know of no other state that had that level of sort of real-time feedback from the ground troops. And that really, really helped, I think, on New York's overall retention.
So the feedback loop and the flexibility. Jan, you have a comment? Education.
I have to go with education. People really need the information about the system and how to navigate the system. But in addition to that, we need to learn more about our health and our health practices and how they contribute to good health and bad health. And also, what's the symptom, right? But a lot of folks, especially newly insured, wait until they have a whole host of symptoms before they show up. And it's really about prevention and about lifestyle change. And I think being able to use those preventive measures is something that we really need more information and more encouragement to do. A lot of us are not encouraged to go to a doc. Call for mammography, and it's a 4-month wait. That needs to go away. That's not encouragement to come to and use your preventive measures. So that's what I'm thinking, education, and then that encouragement to use those preventive services by removing some of those barriers to those services.
So let me see if I can do a teach back globally here. Trust, flexibility are key, and to anticipate that people are going to need more time and to come back more often, and that their situations change, that the states are different, rural areas are different than urban areas. One of the things that many in Washington seem to think is the internet's the answer to everything. However, it's not. And it's an equal opportunity, but not everybody has access or the skills to use it. Everybody is the other theme I'm hearing, may want some help from, in medicine, they call it a learned intermediary. We need some insurance learned intermediaries who can help us with that, which is what the Navigator does. There are also linguistic and cultural and transportation challenges, and Boomerang will be with us. It's a process, as Jan says. We're all learning and fine-tuning. I think it would be good if we turn this over to the audience to ask questions. I know y'all are so full of great information that I just wondered what questions, what are you going to moderate this? What questions, Ruth, you got a question? Okay.
You all have a system.
Yeah.
So let's do exactly what Terry just said. First of all, let me thank Terry and the panel. This was absolutely incredible conversation. We will open it up to the roundtable for discussion, and when we do so, please come to the microphone rather than at your desks. It'll just be easy for everybody to see who's speaking, and be sure you identify yourself. So as we begin to do that, and people come to the microphone, we do have an opportunity to do that, yes. Let me just make a few comments, Terry. First of all, it's very clear that once again we've learned that challenges produce an enormous number of opportunities. And the challenges of no internet, the challenges of long distance for navigators, the challenges of nothing affordable, the trust factor. Look what was accomplished in New York by Elisabeth, and in LA, in Louisiana by Jannette, and in California by Jannette. I mean, just incredible accomplishments with minimal fundings to some degree, except New York. Minimal fundings to some degree. Right. Well, it still sounds like
30 million, 80.
You've done reasonably well. So how critical, what we've learned also, are the social determinants of health, even in facilitating health insurance enrollment. Think about that, the social determinants of health in facilitating health insurance enrollment. Using health insurance is a learned behavior, we heard, and truly that's true. But how do we educate? Let me ask this question. Since Jannette really talked about education, how do we educate the healthcare provider, the healthcare team on these issues to facilitate understanding, which is so critical in directing care in terms of adherence to direction, and patient and physician sharing behaviors, so we can really change the system from critical care or crisis care to preventive care and healthy living. So the education has to not only be on the patient side, it really has to be on the provider team side. How do we do that? I'm going to ask the panel that question, then I'm going to open it up to the...
Jannette, start with you since you work most directly with providers. First of all, were they asked, did the patients ask the doctors and the pharmacists and the nurses what they thought, or?
As far as ACA, or as far as?
About.
And they got an earful.
Well, no, not so. They did not in our clinic. They didn't ask the providers that much about that particular thing. Our patients are, the way we're set up is when you were talking about prevention, we're set up in patient teams. Our healthcare clinic is unique in that, I think. Our patient attendance rate is 95 to 100% for our clinics. Some of our providers have 100% patients show up. All of our patients, if we have 20 or 30 patients come on a Saturday, and we have Saturday and evening clinics also to make it better access for people who are working and they can't afford to sit at a clinic all day waiting to be seen. They're just going, that's another reason why our emergency rooms are so flooded, because of the fact that they'll work all day and then show up in the emergency room in the evening, you know, to get their prescription for insulin renewed, which that is not the appropriate place for chronic care. But we do, if we have 20 patients, they come all at the same time at 8 o'clock. They're there till 11 o'clock. They're having their provider appointment, their team patient approach appointment, and their lab work, their pharmacy, education, all at one thing. We do healthy eating, healthy tasting menus, because we have them there all at the same time, and nobody leaves early, so it's a group visit.
Was there any discussion about insurance during those?
Yes, we did. We did do it during the initial rollout, and we also did, because we have our patients there, we did education sessions during the clinic visit as part of our component. So all those patients know each other, so they're talking about it. They're asking us questions, and they're talking amongst themselves with our team approach to.
So it was a part of your education, yes, rather than the provider, right, having conversations.
Right, because what we do is we do a lot of education in the waiting room because we have everybody there together. And then the providers, who were all volunteers by us, the patient will go in and have their individual time with the provider, nurse practitioner, or the physician, and then they come back out into the waiting room, and we're join back into our education session, whatever it's going to be that day. So.
Do y'all have any tips for Bernie about how to get the physicians and nurse practitioners and nurses?
I mean, I think it's really, I think one of the things that's pretty frustrating in New York City is that there's a lot of provider resistance to insurance. And then the Affordable Care Act is just like a road too far. And so we have a lot of, now Manhattan there's a lot of, we call it bedpan alley. There's a very select, very, very highly regarded, academic medical institutions, and a lot of their providers don't want to take it, or if they're participating with the plans, like we'll go online with the patient and call the doctor to verify that they're really in this Affordable Care Act plan, and then come to pass, oh no, we'll only see them in our hospital-based clinic, not in our offices. So I feel like there's a lot of education needs to happen on the provider side about insurance. I think a lot of providers don't really even understand insurance, to be honest.
So let's do it.
I think there.
that needs to
And Jan,
I was going to say, I think there's a definite wall between those who do billing and those who provide care.
Exactly.
And that's the wall that has to come down in that regard. I also think that as we get more providers who are from the communities that they serve, that will increase education. When you first asked the question, I thought about a doctor I know, Dr. Khadijah Lang. And she's a Muslim, she practices Islam, and she works very well with the Islamic community surrounding her office. She knows how to work with the women. She knows how to perform physical exams with women who still have their clothes on, those type of things. And she knows how to teach, right? Because this is her faith, and she's learned how to work with it and to provide medical care. So because she has come from that community, she's able to provide that community care in a way that is relevant to that community. So as we open the doors to have more people who are of different cultures, ethnicities, etc., then we'll find more solution toward education, because then they will bring that knowledge with them.
That's great. I think last night Gary Puckrein from the National Minority Equality Forum identified just that issue, that there are not representatives of the community who are actually practicing in the community to facilitate what you've just said. So that's very helpful. Okay, I can't see too well with the light in front of me, but I think Rima or Cindy?